This is a presentation about multiple sclerosis, designed for medical students. Background. Multiple sclerosis is a disease which primarily affects neurons in the central nervous system. Neurons are excitable cells which process and transmit information through electrical and chemical signals. A typical neuron consists of a cell body or soma, dendrites, and an axon. This axon is wrapped in an insulating layer of lipid-rich material called myelin, which serves to provide trophic support to the axon and enhance the conduction of signals. In the peripheral nervous system, myelin is provided by Schwann cells, whereas in the central nervous system, myelin is provided by oligodendrocytes. Pathogenesis. Multiple sclerosis is a chronic inflammatory demyelinating disease. That is a disease in which the myelin is continually damaged. The demyelinating lesions of MS, called plaques, appear abnormally hard in pathological specimens, hence the term sclerosis. As a result of this plaque formation, nerve conduction in the affected areas is impaired, giving rise to symptoms. Some precipitating factor leads to activation of the immune system and an inflammatory process. B cells contribute to this process by producing autoantibodies intrathecally towards autoantigens, a variety of which have been proposed as targets. Ultimately, this leads to destruction of myelin. The evidence for this is the oligoclonal immunological bands, which are bands of immunoglobulin that are found in the CSF of more than 90% of MS patients. B cells may also stimulate pro-inflammatory T cell responses and the production of pro-inflammatory cytokines, including lymphotoxin, tumor necrosis factor alpha, and interleukin-6. Alongside B cells, T cells may also be recruited by professional antigen-presenting cells such as dendritic cells, or by soluble CNS antigens, which cross the blood-brain barrier and present to sensitized T cells in the periphery, activating them. These activated autoreactive T cells then have the ability to cross the blood-brain barrier and are cytotoxic to cells displaying the antigen to which they have been activated against. The most abundant type of T cell found in MS plaques is the CD8 positive T cell, although the CD4 positive T cell is also shown to play a part. The cumulative effect of this inflammatory process is death of oligodendrocytes, as well as secondary axonal and neuronal damage. Epidemiology. Based on studies conducted by Mackenzie et al. In 2013, the MS Society estimated that in January 2016, there were over 100,000 people in the UK living with MS. Their estimates suggest a female predominance with a sex ratio of 2.5 to 1. The figures also showed that peak incidence occurred between 40 and 50 years of age, and the maximum prevalence is between 50 to 59 years of age. It is uncommon, although not unheard of, for individuals aged below 10 and above 70 to present with the disease. Risk factors and associations. Although a definitive cause is elusive in MS, it is thought to occur as a result of interactions between the environment and an individual's genes. Various risk factors and associations have been identified. No factor is more strongly associated with MS risk than latitude. That is to say that the further away from the equator, the higher the risk of developing MS. Exposure to infectious agents is a well-explored area. Nearly 100% of patients with MS are seropositive for Epstein-Barr virus, compared with 90% of healthy people. Other pathogens possibly involved are human herpes virus type 7 and Mycoplasma pneumoniae. It is speculated that one way for pathogens to produce or precipitate MS is by molecular mimicry. The pathogens may have peptides with direct sequence homologies with myelin components. Also, it is clear that common viral infections and bacterial urinary tract infections may trigger MS relapses. Smoking has been found to be a risk factor. Multiple studies of sunlight exposure and vitamin D levels suggest a potential protective effect of sun exposure or vitamin D consumption in early life. Consumption of oily fish is also associated with low prevalence. Family history is a risk factor. 3 to 5% of individuals with a first-degree relative with MS are likely to go on to develop the disease. This represents an increased risk of 15 to 25 times compared to the general population. Several genes have also been associated with MS. For instance, various classes of human leukocyte antigen, such as HLA-DR5 and DQ6, are linked with the development of the disease, whereas HLA-C554 and DRB1 are thought to be protective. Clinical presentation. Early on in the disease course, patients may experience non-specific symptoms such as lethargy, headaches, aches in the limbs, and low mood. The focal clinical features of multiple sclerosis depend on where the demyelination has occurred. As a result, 2 individuals with multiple sclerosis may not present with the same symptoms. A typical presentation of MS is internuclear ophthalmoplegia, or INO. It arises due to a lesion in the medial longitudinal fasciculus, leading to an inability to adduct the eye on the affected side, and nystagmus in the contralateral eye on abduction, as well as double vision. MS may also affect the optic nerves, and optic neuritis is another common presenting feature of MS. The patient may complain of loss of vision, usually unilaterally but may be bilateral, which may be painful with a red eye. There may be some colour desaturation in the early stages. Demyelination of the brainstem or areas involved in vestibular function may lead to ataxia or vertigo. Damage to the autonomic system may lead to bladder dysfunction, which can either cause urinary frequency or urgency, or impaired bladder voiding. Fecal incontinence may also occur but is less common. The autonomic disturbance may also lead to sexual dysfunction. When sensory pathways are affected, the patient may experience any number of symptoms ranging from paresthesia and numbness, including loss of pain and temperature, to unpleasant sensations such as burning. Demyelination of motor pathways may leave the patient with weakness, which is a common clinically isolated syndrome. Lots of books describe Ertoff's phenomenon, in which heat leads to worsening of symptoms. However, in speaking to patients, you may find that it is the cold that exacerbates their symptoms. Lermite sign has also been described, although it is not exclusive to MS. It is when the patient experiences electric shock-like sensations or weakness in the upper limbs when flexing the neck. Clinical course. Some patterns of MS progression have been described. The 3 main types will be shown here. Relapsing remitting is the most common and affects up to 80% of individuals. It is characterized by symptoms which develop and persist for a time and then resolve partially or completely. Secondary progressive MS affects approximately half of those with relapsing remitting MS. In this disease pattern, patients may begin by exhibiting a relapsing remitting pattern, but will go on to have sustained build-up of disability independent of relapses. In primary progressive MS, which affects 10 to 15% of patients, symptoms gradually get worse over time rather than appearing as sudden attacks. Investigations. NICE guidelines suggest an initial workup of blood tests to exclude any alternative diagnoses. These include a full blood count, inflammatory markers such as CRP and ESR, liver function tests, urea and electrolytes, calcium, glucose, thyroid function tests, B12, and HIV serology. If a person has an episode of isolated optic neuritis confirmed by an ophthalmologist, they are to be referred to a consultant neurologist. MRI is helpful not only in making the initial diagnosis, but also in keeping track of the progression of the disease. MRI scans may reveal areas of hypointensity on T1 weighted scans and areas of hyperintensity on T2 weighted scans, indicative of plaque formation. The typical appearance on brain MRI is of dorsal fingers, which arise from inflammation around penetrating venules and appear to radiate out from ventricles. Diagnosis. The MacDonald Revised Criteria for Diagnosis of MS stipulates that an individual must demonstrate dissemination of plaques in space and time. This may be shown radiologically, in which 2 or more plaques are seen on MRI. It may also be shown clinically, in which symptoms suggestive of plaques in at least 2 or more anatomically distinct regions, which have developed 30 days or more apart, are noted. Management. NICE guidelines suggest that follow-up should be offered to all patients within 6 weeks of diagnosis. Following this, a management plan may be discussed with the patient. This may include lifestyle advice, such as encouraging people with MS to exercise regularly, and advising them with regards to smoking cessation. Disease-modifying therapies may also be given. This may include dimethyl fumarate, which is considered as an option for treating patients with active relapsing-remitting MS. Drugs such as alemtuzumab and natalizumab may also be given. These are both monoclonal antibodies with different targets. Alemtuzumab targets CD52 on mature lymphocytes. Therefore, it is an option for treating adults with active relapsing-remitting MS. Natalizumab, on the other hand, is only for the treatment of rapidly evolving severe relapsing-remitting MS. It is a monoclonal antibody which prevents lymphocytes from moving into the brain and so prevents them from reaching their target. Teriflunomide is a drug also used for active relapsing-remitting MS. Its mode of action is by inhibiting rapidly dividing cells, including activated T cells. Finally, fingolimod is also an option for highly active relapsing-remitting MS. It acts by sequestering lymphocytes in lymph nodes and prevents them from contributing to an autoimmune reaction. Other therapies may also be used in conjunction with the disease-modifying therapies to control symptoms that the patient experiences. As such, each patient may have a different regimen depending on how their MS affects them.